Hello, today we're going to be talking about the cardiovascular system for children. This is a videotape for pediatrics, and so you have some slides that accompany it, but I want to be able to give you some information that you can use prior to your lecture or prior to your class time, and then we'll be doing some case studies and making this come alive for you. So follow along with me with your slides, and we're going to enter into the world of a child that might have cardiovascular issues. So what in the world causes, you see the slide says CHD, and that stands for congenital heart defects. What would cause a congenital heart defect? Well, there's a lot of different things. Sometimes they just have genetic or chromosomal issues. Oftentimes it's an issue that happened during the pregnancy. So we call that maternal or maybe possibly environmental. So some of the maternal risk factors, if you have a mother that has had drug use, you can see that with fetal alcohol syndrome, they've drunk during their pregnancy. 50% of those children have congenital heart defects, so that's very significant. We can also see that infections can cause congenital heart defects, including rubella or chickenpox, varicella, cytomegalovirus is CMV, toxoplasmosis, that's where you always tell women that are pregnant not to handle kitty litter because there's something in the feces that can cause infection. And then other intrauterine infections can possibly cause congenital heart defects as well. We also know that there's metabolic disorders that can occur. They include things like diabetes in mothers. Insulin-dependent diabetics can have up to 10% risk. And you can see that those are ventricular septal defects, or cardiomyopathy means enlargement of the heart. TGA means TGA is where you have the vessels that are transferred to opposite of each other, and we'll go into those in a while. So the other thing that can cause it possibly would be increased maternal age. And there's about 85% that's just multifactorial. Sometimes it's a baby that's premature, or we talked about genetic disorders. Approximately 90% of children with Down syndrome have congenital heart defects. So those are some of the statistics. This is increasing, but approximately up to 8 children per 1,000 live births. These are statistics that you don't have to know, but just gives you some background on the significance of it in their families. The most common congenital heart defect that we see is VSD. You need to know what the words and the initials are, because you'll see these in charts perhaps, and also on tests. But after prematurity, congenital heart defects can be a major cause, or heart disease can be a major cause in children after prematurity. So VSD is ventricular septal defect, and I'll go into each one of these in a while. So what would be some indicators if a child has cardiac dysfunction or something going on with their heart? And so this is what makes it somewhat different from when adults have cardiac problems. But children will exhibit poor feeding. Maybe if it's an infant, poor sucking, they just don't have the energy to suck, or they're not taking in the calories they need. So automatically in the back of my mind, I'm thinking, okay, they've got nutritional issues. Their heart compensates. Their body compensates, because if their heart is not working well, the pump is not working well, that means they're not being perfused. So the heart says, let's pump faster, and then of course, along with that, the respirations say, I need more oxygen too. So tachypnea and tachycardia are two symptoms that you're going to see. Another thing significant to children, babies, is FTT. FTT stands for failure to thrive. This is the baby that's just not gaining weight. They are very short of breath or activity intolerant, and they're going to be more lethargic. All of this can equate to developmental delays, and we've really tried to build a framework for you about growth and development. So these kids are going to show some developmental delays. We'll see in that they have prenatal history that's positive, that we talked about some of the history of maternal history, and maybe a family history of cardiac disease. Prenatal history can include a preterm birth, maybe a mother that has insulin-dependent diabetes. Another term we call IUGR, intrauterine growth retardation. Those kids with those kinds of prenatal history have more likelihood of congenital anomalies. And then the family history might be that in the family there has been some miscarriages or sudden infant death syndrome, SIDS, or maybe even some adult heart disease. So we always look for that, and maybe a history of congenital heart disease. So let's think about how we assess heart, infants and children. And so in general, when you're looking at the heart and thinking about an adult heart exam, we always think about, okay, where are the valves and what's significant about that? So a heart exam includes, besides the heart directly, the respiratory tract, because you know that the respiratory and the heart, the lungs and the heart are connected. And so if you have some child that has congenital heart defects, you're going to expect they're also going to have possibility of lung involvement, especially if we have right-sided or left-sided heart failure. It always backs up into the lungs, and then right-sided, of course, backs up into the system. So assess the respiratory status and doing a good respiratory assessment. Also, assess the heart sounds. Now, you learned in health assessment using Jarvis about adults that you are to use the bell and the diaphragm when you assess heart sounds. And so what you want to do is make sure that you do use both the bell and the diaphragm. And it's not unusual, it's not unusual to hear murmurs the best with a bell with children. Now, when you're thinking about how to assess a heart, you have to keep in mind anatomy of kids, because children's heart sounds are heard a little differently than adult heart sounds. So that's a real key point. What you're going to find is that infants and young children, and they usually say children under 8, you're going to best hear their apical heart rate at the 4th intercostal space instead of the 5th. So let's review just basically heart sounds and what you'll be hearing. At the 2nd intercostal space on the right side, right border, sternal border, that is the aortic site. And then at the 2nd intercostal space, left sternal border, is the pulmonic sound the best. If you go down to the 3rd intercostal space, you're going to hear the Erb's point. And then the 4th or 5th intercostal space is where you best hear the tricuspid valve. And then you go to the midclavicular line. And if child is under 8, go to the 4th intercostal space. That's where you're going to hear the mitral valve. And remember, the mitral valve is also known as the apex of the heart, or the PMI, the point of maximum impulse. So that if it's child is under 8, go to the 4th intercostal space. If they're over 8, then it's like an adult. You'd go to the 5th intercostal space, midclavicular line. Sometimes I remember that by saying always pumps too much. Aortic, pulmonic, tricuspid, and mitral. Don't forget the Erbs, which is about the 3rd intercostal space on the left side. At every site when you're listening for a heart, no matter if it's an adult or a child, you need to listen for 4 things. Do they have a separate S1 and S2, which is the lub and the dub? And is it an irregular, or regular heartbeat? That's number 2. Number 3 would be, do you hear any extra sounds, clicks, or any kind of extra, either at the beginning or the end of the cycle, any extra sounds? Because there are things called S3s and S4s that can be normal in children. And so thinking about that. And then the last thing is, do you hear any murmurs? So remember to use both your diaphragm when you're going through the sites, and also your bell, and listen for murmurs. That's important. For children, we listen to the apical heart rate for a full minute to really make sure we can have time to listen for all those factors. Because some congenital heart defects affect upper and lower blood pressure differences, you would want to make sure you do a baseline upper extremity and lower extremity blood pressure, particularly if you hear the word coarctation of the aorta. That's a particular defect that you would need upper and lower extremity blood pressures. You also want to check the pulses at the same time, distal pulses for quality and symmetry. And on children, we do check radial, we do check brachial, we also check femoral, and you can also go down and check the feet and check the pedal pulses. So that's really important. So I just wanted to kind of give you an overview of your physical assessment for children. Remember that cardiac also involves perfusion and respiratory. So we look at the child's color, and this is part of that pediatric assessment triangle we've already talked about. When you enter the room, do you see cyanosis or any kind of a problem with perfusion that would indicate perfusion? You can look at the mucous membranes, the nail beds, the soles of feet, especially for children of color that you can't always tell just through their skin tone. I also want to make sure that they're warm and that their capillary refill is brisk. Of course, anything 3 seconds or above would be considered abnormal. Make sure your room is warm temperature. You've got all your equipment that you need as you go through this. The slide, there is a slide that shows, and it's really hard to see this, but shows that a child could have clubbing fingernails. And long-term hypoxemia due to cardiac disease or congenital heart defects can cause clubbing at the fingers, at the fingernail bed because of the lack of oxygen. There are some terms that you should know or variations in children. And so some of these terms are listed here. One would be sinus arrhythmia. And for you all to just review for yourself, sinus arrhythmia means that the heart speeds up as the child takes a breath in. So it's an increase in the heart rate when a child has inspiration, and it's normal in children and in athletes. So that doesn't mean it's irregular heartbeat or that it's abnormal. Remember the apical impulse location under 8, it's at the 4th intercostal space. A midclavicular line over 8, it's at the 5th intercostal space. The S3 may be normal, and it's kind of a vibration. An S3 is considered a vibration. So that is a possible normal that you would have because kids have thinner walls of the heart. If you hear a murmur, you're not a cardiologist, but if you hear a murmur, when you're going back and using the bell of the stethoscope, try to identify, where do I hear it the loudest? Is it which location on the chest wall? And then I want you to think about, do I hear it loudest with S1 or S2, lub or dub? Because most murmurs are benign or okay in children, but if you hear it, then you should have the child turn over on their left side and listen, or sit or move around a little bit and see if you still hear it. So you're listening. Which position's it in? Is it loudest in lub or dub? Lub is called a systolic, and dub is, which is S1. Dub is S2. Diastolic murmurs are always more significant and concerning than systolic murmurs, so that would be something. You are just to report it, try to figure out what you hear, and then somebody is going to grade it, and we'll talk about that in a minute. So this is just a reminder to you when you're talking with children about their heart. If this little boy looks like he's about 4, always use your medical play, if you can, with your 3 to 5-year-olds, and let them listen to their own heart, or let them listen to mommy's heart. Make it a game so they'll be cooperative. So an innocent murmur does change with position changes. Innocent murmur meaning more like a benign murmur. It is, you can't hear, if you hear it in, like they're sitting up and then you turn them over on their left side, it might go away, so it's not as significant. If you have a very significant murmur, it's not going to go away. It could even become louder as you change positions. An innocent murmur mostly occurs, we talked about, in S1, which is systole. Not easy to hear. It's very soft. It doesn't transmit anywhere. The child looks perfectly great. They don't seem to have any loss of weight. There's normal growth and development, and their vital signs are normal. So those are considered normal cardiac anatomy and cardiac function. And what you're going to see with innocent murmurs is that about 50% of all kids have an innocent murmur at some time in their life. It just reflects a flow of blood in the heart. Remember, a murmur is turbulent blood flow in a heart. That's what the name of it is. If someone finds a murmur that is at advanced practice, they might say, when is it like we talked about, what's the timing of it, how long does it last, how intense or what's the quality of it, location, and what was the position of the child. And to classify a murmur, remember that murmurs are classified 1 through 6, and they use Roman numerals. So it's a 1 would be, looks like an I. And anything that's a 4, 5, or 6 murmur that's really loud, it is usually associated with a thrill. So a 4, 5, or 6 murmur is associated with a thrill. And a thrill is a palpable vibration or tremor if you put your hand over a chest wall. So if you hear a very loud murmur, take your hand, put it over the aortic, the pulmonic, the base of the heart, and put it over the different areas of the heart and see if you feel a palpable vibration, and that is called a thrill. So when you have a child in general with a cardiac issue, the nursing care is pretty broad. Basically what we're trying to do is we're trying to look at the child holistically and say, if a child has a cardiac issue, we are going to have problems with perfusion or oxygenation. That's not even actually up here. We are going to have issues about nutrition and how we can keep them hydrated and make sure they don't lose weight. We want to concern ourselves with temperature. We also want to encourage rest and take time with that, administer medications, and do some client and other kinds of family teaching. So we're going to take each one of these, and just for reference purposes, your ATI book lists the cardiac information in chapter 20. Your Wong is talking about this cardiac information in chapter 34. So what I think you should come to class and expect to do is we will go over some of these interventions about the nursing care of a child with cardiac issues. And so I want you to look those up so that you'll be ready for them. In each of these areas, what are some interventions you can do? And we will talk about some of the specifics. There are diagnostic tests that children go through, and sometimes after diagnostic tests, or if a child is in a neonatal intensive care, they have to have cardiac monitoring. And there's a little picture here of a child that's hooked up to an ECG, electrocardiogram, and has some other issues. You can still see the umbilical cord, so this is a tiny baby. So some of the diagnostic tests that we go through, one of them's really that's significant is cardiac cath. And cardiac catheterization is just one of the types of things that's invasive for children. Before we go into that particular one, a couple other procedures or diagnostic tests that we will be talking about will be the ECG, electrocardiogram, and you all are familiar with that, and sometimes children need even 24-hour Holter monitoring if they're having some kind of dysrhythmia. They possibly, depending on the size of the child or the age of the child, may need sedation for some of these procedures so that it can be accurate and they would be more cooperative. So they may start, of course, with, before they're going to do a cardiac cath, which is invasive, an ECG would be baseline. Other things that you might see done would be radiography or chest x-ray. A chest x-ray, of course, can detect an enlarged heart. Cardiomegaly is the term for that. It can also look at increased or decreased vascularity, which can be congenital anomalies. The gold standard for determining cardiac defects in preborn children would be ultrasound. So even children that are in utero can have through ultrasound, when the mother goes in for prenatal care, they can actually look at the chambers of the heart and see, do we see any openings at this point? Are all the 4 chambers there? Do we see any holes between them, any vessels that are abnormal, so that they can be prepared? There is even interventional in utero care for children. Another thing that you'll see would be MRI, and that would be to basically vision soft tissues or tumors or how thick the heart muscle is. Of course, if they're going to do an MRI, they should be NPO, and at least 4 hours before the test, and then use sedation possibly. So they're going to need to lie still 1 to 2 hours, and that's why sedation would be needed for infants and small children. So other kinds of tests that you're going to see, lab tests that are important, would be things like, of course, a baseline hemoglobin and hematocrit. We want to see what is going on with their iron levels. Some other things you might see that are done are WBGs and ABGs. We want to see with ABGs if we've got a good oxygen level. We also may want to see if there's any C-reactive protein and ESRs, and of course baseline electrolytes. I also think some cardiac function tests would be good. We want to see what the child's cardiac output is and their mean arterial pressure, but some of those things can be determined through cardiac catheterization. And that's where we're going to go now, is what is cardiac catheterization? And it is an invasive test, and it's used for diagnosing defects. It also can be used to repair small defects if they're small enough, and also evaluate some irregular heartbeats. It can take very precise measurements of oxygen level in the different heart chambers and pressure levels. It can see how the blood is flowing and the cardiac output. And we need to understand how important that is. So basically, a catheter is inserted into the child, usually the femoral artery, or it could be the right artery, and it goes through the right atrium. It's threaded into the heart, and they use fluoroscopy. They can put in a contrast median, iodine base, so we want to check allergies for the child, and it will be injected, and then images of the blood vessels and heart can be taken at that point. So it's a very important thing, and it really does have some risks to do a cardiac cath. This, the slide that's with your PowerPoint just talks about all the things that they can do with cardiac cath in children. They can diagnose stenosis of the valves, or coarctation of the aorta that keeps closing, or mitral stenosis. Those are some things that they can diagnose. They also, with cardiac cath, can transposition of the great vessels. That's one of the things that they can look at and correct. And then sometimes some complex single defects like ventricular defects, or ASD is atrial septal defect, or maybe correct pulmonary artery stenosis. So what they do is they take this wire. Of course, the child, before this child has this procedure, since it's invasive, there are some risks of arrhythmias and bleeding and emboli, perforation. It can cause all kinds of things, so there has to be informed consent with this. You need to perform a very thorough nursing history and physical exam. You would want to ask about if the child has any bleeding disorders, and look and make sure there's no diaper rash down at that femoral area if that's the site they're going to use. Because if a child develops a severe diaper rash and you put a needle or catheter inside that femoral artery, that could be an import of bacteria directly into the heart. So if your child wakes up and they're going to have a cardiac cath, and your patient wakes up with a rash that's going up into that femoral area, you'd have to cancel the procedure and notify the healthcare provider. So we also want to make sure that we get a baseline height on the child and weight, because the height is going to determine the size of the catheter, and the weight is going to determine how much medicine the child will need. And then also have some baseline vital signs and O2 sat before you start. So make sure you have an informed consent. The physician would need to obtain it, but make sure it's there on record. And then make sure you've also identified iodine and shellfish allergies. So it depends on how old the child is, but certainly you're going to do parental teaching, and if the child is old enough, teaching for the child, showing them the equipment, explaining what's going on, monitors and dressing, and describing how long the procedure is to the child and how the child will feel and if they're going to be asleep or not. The child for a cardiac cath should be NPO 4 to 6 hours prior to the procedure, and they may want to have you hold oral medications. It could be that they do IV fluids in advance, pre-procedure, because of polycythemia. You are going to absolutely do baseline, we talked about vital signs, but you're also going to be doing baseline pulses. So before a cardiac cath is done, you are going to make sure that you do a pedal pulse on both sides and mark it with an X, and that's not going to wash off, because that's one of the major assessments that you do to make sure you've got good perfusion afterwards. So go to do both dorsalis pedis and posterior tibial pulses in advance. Then the amount of sedation should be based on the child's weight per kilograms, and it's usually, of course, it's the physician's responsibility to give that, but the nurses should be also understanding that. You also want to tell the parents about when the child's finished, how long they're going to have to lay still, and how the dye, if they're awake, can cause a feeling of warmth, and it also makes you want to feel like you could get nauseated, or it almost makes you feel like that you need to pee. So okay, the child has gone through a cardiac cath, and again, looking at my slides, sometimes they use this for surgical interventions. Also, they can do that, but back to cardiac cath, the child has come back, and they're going to be monitored cardiac and pulse oximetry because of some of the complications. We talked about bleeding, bradycardia could be a complication. When the child comes back, I'm going to keep that pressure dressing on wherever it was over the artery. I'm going to watch for saturation of blood, and if I see that the dressing is saturating, what would be your response? It's like ABCs. C for circulation. You're going to reinforce, or if you see a lot of blood coming through, then applying direct pressure above the site is what you would do to stop the bleeding, and for as long as you need to. Assessing the vital signs would usually be every 15 minutes for about an hour, kind of like post-surgery vital signs. Checking your apical pulse. You're going to watch for hemorrhage. You're going to absolutely check those pulses. You already put an X to them that are distal to the site to make sure. Because if you have a 0 or even a 1+, 0 of course is a medical emergency, no perfusion's getting to that extremity, you've got to call immediately, because that's a medical emergency. Call your healthcare provider. There could be a clot. That person could lose their extremity with very little time involved. You also assess, along with the pulse, temperature and color of that extremity distal to the site, and because arterial obstruction is could be life-threatening for that limb. Hematoma or bleeding, every 15 minutes, the first hour, really be watching for that. You want to keep the pressure dressing on and reinforce it. Don't take it off unless you have a physician's order. You also want to assess the child's intake and output. We know that cardiac output is associated with urinary output. Your kidneys need 25% of your cardiac output to function. So if you have some kind of issue that's affecting cardiac output, it could affect your kidneys as well. Make sure you've got adequate urine output and that the child's not experiencing hypovolemia or signs of dehydration. You're going to encourage oral intake, starting with clear liquids, and then actually wanting the child to excrete the dye, so fluids will be started. Make sure there's no nausea, and you're trying to flush this child out, so you got to get that contrast median out. Infants may be at risk for hypoglycemia, so IV fluids with dextrose may be necessary. Keep the extremity that was used in a straight position, usually 4 to 8 hours after the procedure. Remember that if there's bleeding at the site, the first response is to stop the bleeding. Direct continuous pressure about 1 inch above where the catheter went in, and then after that it could take up to 5 to 10 minutes for that bleeding to stop. So position the child flat and then notify the physician or primary care provider immediately. There might be that there's going to be additional fluids, maybe the IV fluids going up, or even other kinds of medications. Some other complications besides hemorrhage for a post-cardiac cath would be nausea and vomiting, possibly low-grade fever. And again, another emergency would be no pulse in that extremity that was catheterized. So families going home, we want the child to limit their activity for at least 24 hours, increasing their fluids, and monitor for complications of bleeding, infection, and thrombosis. That they don't need to take any tub baths, and really wait a couple days before going back to school. The dressing will be taken off. That pressure dressing should be taken off and just a Band-Aid put on, but they don't want that to re-bleed, so that's why it's important. Now, it possibly could be that after a cardiac cath, it's determined that the child needs heart surgery. So if the child needs heart surgery, there's going to be, pre-op and post-op care for the child. And some of the surgical interventions that are on the slide says open heart or closed heart procedure. There's something called a Da Vinci where they can take little short, it's non-invasive, or it's less invasive, where they can use very short little incisions to go in with tubing. It could be that children with congenital heart need stage procedures. They don't, like if they have 4 defects, they may be able to do 1 or 2 and then wait till the child grows and then do a couple of more. So one of our responsibilities would be to prepare this child and the family for these procedures. And of course, if it's going to be major cardiac surgery, prepare them for that as well. Obviously, some of the stuff that you learned in the foundations would be related to surgery, including, the fact that the child will have an ET tube until the ventilator is no longer needed. It could be that the child will need chest tubes after cardiac surgery, and so chest tube care. And then, of course, fluid and electrolytes, we're monitoring that, supporting the child and their family for shock, hemorrhage, congestive heart failure is a possible complication. The child, if they have a cardiac surgery, a heart surgery shouldn't be picked up, for instance, immediately by the parents, and so just some of that teaching and reassurance needs to help them. So what I think would be helpful now, this is just showing you a little picture of some of the interventional diagnostic areas and also maybe a surgical suite. This is showing you a nurse taking care of a child, possibly post-operatively, and then what a chest tube might look like. Chest tubes can be part of their care, and so just reviewing how to take care of a child with chest tubes or anyone with chest tubes, making sure that the system maintains intactness, that there's some bubbling going on. If a chest tube accidentally came out, putting some kind of gauze over that so that there's not going to be sucking in would be important. Putting, if it comes out from the system, putting it into some bubbling water would be important too. There is something called post-pericardiotomy syndrome, and it could actually occur in an immediate post-op period, 7 to 21 days, and so these are some of the things to look at. So your ATI goes through a little bit about the cardiac congenital heart defects and a couple of infections that you might see, more than they go through having cardiac surgery. So that's where it kind of picks up, but your WONG does go through some of those other kinds of things. So that's what we're going to talk about next. We're going to talk about the different cardiac defects. So, and there's a wonderful chart in chapter 34. It is a chart that shows you all the defects, and it shows you the pictures of the defects and what kind of things to expect. So when you're thinking about cardiac, 2 types of defects. One is congenital, and that's what children are born with, and then there are also acquired defects or processes. So what we're going to basically go through first would be the congenital, but I want just you to be reminded about cardiac pressures. So you've learned this in patho, and you learned this in anatomy and physiology, that there's different pressures in the heart. And so if you look at this little slide about reviewing cardiac pressures, basically blood flows from the greater pressure area to the lesser pressure. So thinking about the heart, what are the two places that have the most pressure? Well, the first one would be the left ventricle. It's the highest. So the left ventricle, as you can see here, has 100 to 140 millimeters of mercury. And then the next thing that has a really high pressure is the aorta. Of course, the aorta is the vessel that takes blood to the systemic person, and it's right off the left ventricle. So yes, it has the high pressure too. It can be 96 to 140. So if you have a hole somewhere in the heart, you're going to think, now notice the right side of the heart, 0 to 8 for the right atrium, 4 to, actually that 4 to 12 should be the right ventricle if you want to, I'll correct that slide. But so the right ventricle has 4 to 12. The right atrium has 0 to 8. So if you have a hole in the heart, then you're going to think it's going to be a left shunt to a right shunt because there's more pressure in the left side. And we will go over that some more. You should also know that there's an older classification that you might see of congenital heart defects. So the older classification is that either they're acyanotic or cyanotic. A means without, and so prefix of A means without cyanosis or the child turning blue, and then cyanosis means, of course, that they've turned blue. So if they, if you have a cyanotic, they may be pinkish, but they also may develop congenital congestive heart failure or become cyanotic. So that's the older classification. Now, instead, we talk about how much blood flow is getting to different places. So there's a chart in Wong that talks about the newer classification. And so it's talking about either increased pulmonary blood flow or decreased, or maybe there's an obstruction or maybe mixed blood flow. So if you've got increased pulmonary blood flow, that's probably because of a left to right shunt, and we'll talk more about that, and congestive heart failure. If you have decreased pulmonary blood flow, meaning blood flow back to the lungs, that could be because of maybe you've got some kind of tetralogy of Fallot or some other cyanotic kind of defect. Obstructive defects could be some of the vessels are obstructed, so you could either get congestive heart failure or maybe some kind of cyanosis. And then there's the mixed blood flow. You do have classifications of congenital heart defects in Wong, and I've got it also on your slides. So it shows acyanotic and then cyanotic. And so the major ones we're going to talk about today will be, and that you're responsible for, would be under acyanotic, or ones that are primarily without blueness, would be the increased pulmonary blood flow. If you look down, it's ASD, which is atrial septal defect, VSD, and then PDA. Those are the three most important ones. And then under obstruction of blood flow, which is also acyanotic, we're going to talk about coarctation of the aorta, and we're also going to talk about stenosis. Either the aortic valve is stenosed or stuck, or the pulmonic is stenosed or stuck. Under the cyanotic side, you're going to see under the cyanotic side several of them. One is called decreased pulmonary blood flow. And I mentioned tetralogy of Fallot, and tetralogy of Fallot we'll go over, but it is where there's 4 defects. Tetra means 4. You can also have a tricuspid valve that's just closed, which is atresia. And then there's some that's mixed blood flow, and you should at least know what they are. Transposition of the great arteries. The arteries are reversed. The pulmonary artery is on the left side and the aorta is on the right side. Or there might be some other things going on. Maybe even the left heart is small. But the most important ones that we're going to talk about is tetralogy of Fallot under cyanotic, and you should at least be familiar with the other ones and what they mean. So the next thing we're going to talk about would be the pulmonary defects that are increased pulmonary blood flow. It could be that there's an abnormal connection, like a hole between the heart, and that causes more blood to come from the left side over to the right side and back to the lungs. And that's where you're going to see the lungs are really stressed and can get pulmonary hypertension, and less blood is actually going out to the systemic body. So it does affect cardiac output. That's why it can be a problem. So when we're looking at these pictures together, the major ones for increased pulmonary blood flow are ASD, VSD, and then the PDA. So atrial septal defect, ventricular septal defect, which is the most common, and then PDA. So with the ASD, you can see that there's an opening between the two atriums, which are the top chambers of the heart. Now, depending how big the hole is, depends on what the symptoms would be. But the pressure is greater, remember, in the left atrium than the right. So the blood comes left to right shunt, and it goes back to the lungs, which causes stress on the lungs. And that can cause the more distension in the right side of the heart. So that's one of the things that can happen. And this is maybe one, depending on how big it is, that procedures that can be dealt with cardiac catheterization. Now, looking at the VSD, something happened where there's an opening between the ventricles. Once again, depending how big it is, it could be asymptomatic, or it can be that the child is starting to have symptoms of congestive heart failure. It can occur anywhere in the muscle, or, so again, about a quarter of the congenital heart defects are the ventricular septal defect. It can be pinhole size all the way to in complete absence of the entire septum. So this is why it's an important one to look at. So it's, again, one of those things that's a left to right shunt. And it's important for a cardiac cath may be possible, but it's a very characteristic murmur. It has a very characteristic murmur, and congestive heart failure is common. It's possible that, it also, as you can see, keeps bringing more blood back to the lungs. So pulmonary hypertension is also a risk for this particular one. They can maybe do a repair, catheterize, or maybe with some other kind of cardiac procedure to repair this. The next acyanotic or acyanotic congenital heart defect is called the PDA. And so usually the PDA is part of fetal circulation, and you'll learn that in your maternity class. But usually this little patent ductus arteriosus should close by about 15 hours after birth. Sometimes you'll see that it takes up to 24 hours after that, that first breath. It should be closing. So the ductus closes because of an increase in arterial oxygen concentration that follows the initiation of pulmonary function. So that's important. So basically about 5 to 10% of all congenital heart defects are the PDAs. It's more prevalent in little girls. But what you can see is happening is if it's a small PDA, it's asymptomatic. Remember that the aorta has higher pressure than the pulmonary artery. So what we're talking about with the patent ductus arteriosus is there's normally an opening in fetal circulation between the aorta and the lungs, because we want to bypass the lungs while the baby's in utero. So if it's a large PDA, however, this child's going to have tachycardia, shortness of breath, and symptoms of congestive heart failure. They could have a hoarse cry as well. So these are some of the manifestations. You also could see that they could have bounding pulses and a widening pulse pressure. Remember what the term widening pulse pressure means? It means that you have a very high systolic pressure, and then the bottom, the diastolic pressure lowers. So a widening pulse pressure, it can occur. You also have something with a PDA called a machinery murmur, and it's at the upper left sternal border. So upper left sternal border is where you might hear this machinery-like murmur that's audible in both S1 and S2. Those are some characteristics that you would hear. You can have a definitive diagnosis with an echocardiogram. And so, there's different ways to take care of this, but again, your chart in Wong really talks about this. This can be closed probably interventionally through a cardiac cath. The next slide just basically shows you what is when you have a heart that has a patent ductus arteriosus versus what a normal heart looks like. So the question about all this is, what would you do? What is your nursing care for a client that has increased pulmonary blood flow? What would be some of the things that you would think about would be care? Some of the priority nursing diagnosis and the priority actions. I want you all to be thinking about that and try to come up with some answers for class. What are some nursing diagnosis if a child has a increased pulmonary blood flow and possibly congestive heart failure? What would be some interventions that you think would be appropriate based on some nursing diagnosis? And I want you to think of congestive heart failure, someone with congestive heart failure, and some of what they may be experiencing. So if you're looking at these and you want to review it, in page 201 of your ATI book, chapter 20, it does talk about some general interventions that you can look at that would be helpful for a child perhaps with this. We'll talk some more about that in class. Now, there are some obstructive defects as well that could be considered acyanotic, and the three that are listed here are COA, coarctation of the aorta, or aortic valve stenosis, or pulmonic stenosis. So when you think of coarctation of the aorta, I want you to think of the word constriction, that it is a constriction of the aorta. Let's look at the next picture. So if you see this heart model here in this picture, you see that everything's normal inside the heart, and then as the aorta is the blood's coming out of the aorta, three vessels take the blood up to the head and the upper extremities. Right after those vessels is a constriction or a coarctation of the aorta. So you can imagine that here's the blood trying to go through that. And so what happens is the blood pressure is so high that it's kind of stuck, that it really whooshes up to the head and to the upper extremities. So with coarctation or constriction of the aorta, this is the defect that you have high upper extremity blood pressure, bounding pulses, and maybe headache, and then the lower extremity pulses and blood pressure are decreased. So if you hear of a diagnosis of a suspected COA or coarctation of the aorta, already put in your regimen for a nurse to take baseline upper and lower extremity blood pressures and pulses. The signs of this would be high blood pressure, or like I said, and bounding pulses in the arms, weak or absent femoral pulses, and cool lower extremities with low BP. You can also see signs of congestive heart failure in infants, and this condition can really deteriorate rapidly. Older children might feel some dizziness, headache, fainting, or epistaxis. They can actually get nosebleeds from their hypertension. Your little patient's at risk for ruptured aorta, aortic aneurysm, or stroke with this, so it is very significant. Usually they would do a non-surgical balloon angioplasty with cardiac cath to repair this. It's usually effective. Usually don't require bypass if you do a surgical procedure, since it's outside the pericardium. The post-op complication for this particular procedure would be hypertension. They usually try to do this before the age of 2 years old. You can also get another obstructive would be aortic stenosis, and that's, as you can see from the picture, the aortic valve is just stuck. It's narrowing. It's usually malformed, and so it's usually malformed, and it can cause increased resistance in the left ventricle and decreased cardiac output. So that's what happens is not enough blood's coming out to the periphery. You're going to have low kidney perfusion and other things. So that's when you start getting symptoms. The clinical manifestations for aortic stenosis would be decreased cardiac output, pulses are faint, hypotension and poor feeding, and then tachycardia. They are going to have a murmur. They're exercise intolerant. Older kids could say they have chest pain or dizziness with standing. This also can be treated with a balloon angioplasty to dilate the valve. And it's sometimes with these obstructive disorders, they have to do them a couple of times because they reoccur. coarctation can reoccur, and some of these stenosis can reoccur. Valve stenosis can reoccur. All right. This is just showing you a normal and a defect for aortic stenosis on the next slide. And it also is showing you that there is something called pulmonary valve stenosis, and it's kind of showing you how a balloon angioplasty can correct that. But what can happen with pulmonary artery stenosis is the right ventricle gets very large. It's called right ventricular hypertrophy, and then decreased pulmonary blood flow, which means the lungs are not getting enough oxygen, which can also lead to congestive heart failure, which is significant. Again, angioplasty, balloon angioplasty can help dilate that pulmonary artery valve, and some other things possible. Those are some things. So we've talked about some acyanotic or decreased pulmonary blood flow. We've talked about VSD, ASD, coarctation of the aorta, and then some obstructive things like aortic stenosis and pulmonary artery stenosis. Now we're going to go to some what we call decreased pulmonary blood flow defects. And the biggest one that we talk about is tetralogy of Fallot. And tetralogy of Fallot is meaning 4 major defects. With tetralogy of Fallot, and here's the picture, you're going to see that it absolutely has a VSD. So there is a hole between the ventricle. And the blood is trying to come through that left to right shunt. Well, the heart is not going to let it, because you can also see that a second defect is pulmonic stenosis or pulmonary artery stenosis. So left to right shunt, I'm trying. The artery to the lungs is saying, no, you're not. So all of that blood, that pressure gets greater in the right ventricle. So the third defect, the first defect is a VSD, the second defect is the pulmonary artery stenosis, and then that thickened wall, the right ventricular hypertrophy, is the third defect. And that's not the side that's supposed to have the thickest wall, it's supposed to be the left. And then lastly, what you see is there's a dotted line here on this slide. The aorta is supposed to be all the way over to the left ventricle. And what you're going to find is that the aorta is on the fence line. It's on the fence line between the left ventricle and the right ventricle. So here's what happens. This tug of war between the left to right shunt and the blood coming back the wrong way, and then the pulmonic artery saying, no, you're not. Some unoxygenated blood slips out into the aorta and goes out into the child's body. And that's what causes the child to become cyanotic. That's what causes the child to become cyanotic. So that's where the child, it depends on, what's going on, but this is what's called TET spells. You'll see as you're reading something called TET spells or blue spells, which are acute episodes of cyanosis and hypoxia. And so it may be that after feeding or they're crying, but a child that has all that congestion on that right side of the body can also get coagulation and have risk for emboli. Lower levels of consciousness, sudden death, or seizures. Usually, when the TET spells and the hypercyanotic spells increase is when they talk about repairing this, and this is usually a staged repair. They may do a complete repair sometime in the first year of life, but they're going to repair the VSD, they're going to repair the stenosed area, they'll patch that right ventricular outflow, and then that will help, of course, reduce the size of the heart as well. So one of the things that you're going to see is if you have a child that's crying and all of a sudden becomes blue, what would be something that you would do for that child? So this is a question. A child hospitalized with tetralogy of Fallot has an acute illness with fever. The nurse enters the room and finds the child cyanotic, tachycardic, and tachypnic. What should the nurse do next? And here are your options, and I'm going to let you think about those questions. But this is a visual of what the right answer is. You put the child in a knee-chest position, and that helps relieve the cyanosis. We'll talk some more about that in class. Another thing that you might see for a child that is having cyanosis is that they just don't have an open tricuspid valve. And so they also have mixed, usually they have an ASD. They're going to also have mixed unoxygenated blood going out to the periphery. So sometimes what they'll do with that is a shunt. Now, some others that you might see, and ATI might talk a little bit about, they do have them in their charts on page 198 and 199. There's a chart with all these defects in it. But transposition means that there's a pulmonary artery is leaving the left ventricle and the aorta exits from the right, and there's no communication between the systemic and the pulmonary circulations. So the only way that this is going to work and the child's going to be able to live is if they have a PDA or a septal defect to permit blood flow. That's the only way this is going to work. So the surgical treatment of choice is arterial switch to resect and reanastomose the great vessels. So it's a pretty major surgery that goes on. Another thing you might see is that it's a rare defect. It's called an anomalous pulmonary venous connection. I don't think we need to talk about that. Or the other one that you sometimes see is that the left side of the heart is very underdeveloped, and that's called hypoplastic left heart. So basically, what is the care for children that have some of these congenital heart defects? This is a question. The nurse is caring for a child with a cyanotic heart defect. What assessment findings in the client would not be indicative that the child is at risk for CHF or congestive heart disease? So basically, this is a negative question. Which of these would be a good thing and not indicating congestive heart disease? Would it be rapid weight gain, increased blood pressure, hepatomegaly, or oxygen saturation increase? Think about that, and we're going to talk about that. So children do develop, because of congenital heart or other things, sometimes they develop CHF. And so some of the symptoms that you'll see in CHF in adults can happen in children. And of course there is right-sided congestive heart failure and left-sided congestive heart failure. And when we're thinking about that, we're thinking about impaired myocardial function. We're thinking about pulmonary congestion, and we're thinking about systemic venous congestion. Pulmonary congestion is because of left-sided heart failure, and then systemic venous congestion is because of pulmonary congestion is because of left-sided heart failure, and then systemic venous congestion is because of right-sided heart failure. So when we're in class, we're going to ask these questions. What would be the nursing care of a child with congestive heart failure? I want you to be thinking about the priority diagnosis and interventions that you would do. I would like to cover a couple other acquired cardiovascular diseases or disorders, and then we'll also talk about some of the medications that are going to be used with children. But there is an acquired inflammatory or infectious process called endocarditis. And endocarditis could be bacterial, or it can be infective endocarditis or subacute bacterial endocarditis. And basically what we're talking about is infection in the valves and the endocardium. Usually that there is some kind of sepsis in the child. Something has entered into the child, gotten into the heart, maybe because of a cardiac cath, that aseptic technique wasn't used, or something else going on. But it's usually a sequela of sepsis in a child that has cardiac disease or congenital anomaly. It could be staph or strep. It could be candida or a gram-negative bacteria. So if a child has any of these infections, we usually use high-dose antibiotics like penicillin, ampicillin, methicillin, cloxacillin, streptomycin, or gentamicin are some of the drugs that they use. We can also use amphotericin for fungal infections. If you have endocarditis, then you're going to need antibiotics or treatment 2 to 8 weeks. And then if it's not successful, this child can actually develop CHF or valvular damage. In order to prevent this, prophylaxis is usually used if a child has at risk for it. Before dental procedures or some surgeries, they'll give them an hour. They'll give them like an hour before a procedure a high dose of antibiotics to prevent this. And some kids I know with pulmonary stenosis have to do that with surgical procedures. So this is what the inside of a heart looks like for a child that had endocarditis. You can see some of the the coagulation and the vegetation there. They call it vegetation, but the child becomes at risk for clots when they have endocarditis and other things. Some other symptoms you'll see on this slide, you can see that the child has hemorrhages on their nail beds, in their conjunctiva. They have little hemorrhages on the soles of their feet, and then they have some other things that occur. So infective carditis, so splinter hemorrhages normally seen under the fingernails. They're red for the first 2 to 3 days, and then they turn brown. Conjunctival petechiae is what that's called. They do get some other kinds of tender subcutaneous nodules in the digits of the fingers, could be another sign. And then there's something called Janeway's lesions. They're non-tender erythematous hemorrhagic or pustular lesions on the palms or soles of the child's feet. So these are some things to think about. Okay, besides endocarditis, another acquired disease that children get is called rheumatic fever, and rheumatic fever can become rheumatic heart disease. So with rheumatic fever, it's inflammatory, usually group A, beta hemolytic strep. And so this is what we call a post-strep complication. It's usually self-limiting, but rheumatic fever can become so if a child has a strep throat that's untreated, it can become rheumatic fever. What you're going to see is that it affects the joints, the skin. It can actually go and become more serious and affect the brain and the heart. Rheumatic heart disease becomes a major complication of RF, and it can damage the valve. So this next slide is just basically showing you what a strep throat might look like. And I treat strep throat all the time, but if you have a strep throat that has little petechiae, large tonsils, this looks like there's pustule on them, a strawberry tongue, those are classic signs of strep throat, as well as a headache and stomach ache in children. So what are some clinical manifestations of rheumatic fever? We talked about carditis. It affects the heart. It can also affect the joints, polyarthritis. Erythema marginatum is where you have a rash that I'll show you a picture of, and then you also have subcutaneous nodules that can occur. So the carditis involves the endocardium, a pericardium, or myocardium, and the most common valve that's affected is the mitral valve. Arthritis is reversible, and it does migrate. It's in the large joints like the knees, the elbows, the hips, the shoulders, and the wrists. The erythema marginatum is a rash. It's usually on the trunk that occurs. It's red macules. It has a clear center and well demarcated borders. It's almost like a sandpaper feeling rash. And then the weird thing are these subcutaneous nodules, and I'll show you a picture of those, but they appear over the bony prominences of the hands, the feet, the elbows. They persist for a while, indefinitely after the onset of the disease, and they just resolve. There can be also hemorrhagic bullous lesions, which cause swelling in the connective tissue, and that's in the heart, blood vessels, brain, and on the serous surfaces of the joints and pleura. So why is that important to know? Well, let me just show you first of all. There's the rash, a rash showing you on the trunk. It's very irritating. It can be very uncomfortable. And here's a picture of a subcutaneous nodule. It's kind of soft. Another manifestation that we didn't talk about is something called St. Vitus dance or chorea. Chorea reflects that the brain has been infected and it's CNS involvement. Usually girls get this more than boys, and it's sudden aimless movements of the extremities. It involves involuntary facial grimaces, speech disturbances, muscle weakness, and emotional lability. It's worse with anxiety, and it goes away when the child sleeps. So this is very scary. It can last 6 months past the disease, and the parents are going, what's going on? Is my child having cerebral palsy? But it's called chorea. C-H-O-R-E-A is another name for this, and it reflects the neurological involvement. So in order for rheumatic fever, which is this post-strep infection, not to become rheumatic heart disease and up to the neurological manifestations, we have to treat strep, tonsillitis, and pharyngitis aggressively. Now, the drug of choice would be penicillin G or penicillin V. They also can use sulfa drugs or erythromycin. And so some other things that I just want to tell you they use for rheumatic heart, if it becomes rheumatic heart disease and we have the possibility for coagulation, this is one condition that we use aspirin in children for. Now, I know we avoid aspirin like the plague if a child has fever or upper respiratory infection because of the terrible disease called Reye's syndrome. And Reye's syndrome is a terrible disease that can manifest itself into brain swelling and liver damage. So we want to prevent it. But this particular rheumatic heart disease does use aspirin to help with the coagulation. It's kind of an anticoagulant, and that does help. Another acquired disease that you might hear about is called Kawasaki's. And there is a little blip about Kawasaki's. Rheumatic fever is on page 206 in your ATI book. Kawasaki's is on page 210. So Kawasaki's is basically a disease that also has implications for cardiac. What you're going to see with a child, there's acute phases, and that's a child that has high fever. It's not being responsive to any kind of antipyretics. Usually the fever is like 102, lasts 5 days to 2 weeks, and it's unresponsive. The child is going to show some other symptoms, like this child in the picture, red eyes without drainage, red chapped lips. They're going to have a strawberry tongue that has white coating or red bumps, oral mucous membranes that are red. Their hands and their feet get really swollen. Red palms and soles, non-blistering rash, joint pain, lymph nodes. Now, that's one of the acute phases. And then it goes to something called this subacute. This is where the fever resolves and there's a gradual subsiding of some of these other clinical manifestations. During this time, the child is still irritable, and then they do something kind of weird, and that's where they start having peeling of their skin around their nails and on the palms and soles of their feet. It takes about 6 to 8 weeks from onset for this to go away, and you're going to see that their lab values can show differencing things. There also can be heart manifestations, so myocarditis, pericarditis can occur. So looking at Kawasaki's disease, this is another thing that's showing you some of the manifestations of it and what you would want to do for it. So what nursing intervention, is my question, would be best to support the goal to promote comfort for a child admitted to the hospital with Kawasaki's disease? There's several answers here for you, and I'll let you look at those. And so when we're looking at these questions, and we'll answer them in class, there's also showing you that some of the treatment for Kawasaki's disease includes immunoglobulins, IV gamma globulin, according to facility policy. And once again, ladies and gentlemen, aspirin is used, 80 to 100 milligrams per kilogram per day. It helps with the fever. It also, aspirin can also be used as an anti-inflammatory. So Kawasaki's disease really is a vascular disease. It causes inflammation inside the vessels, and so both of these things really help. The IV immunoglobulin reduces the duration of the fever and the incidence of coronary artery abnormalities. It has to be given within the first 10 days of the illness. The aspirin is given for fever and for inflammation. And then after the fever is gone, we continue to use aspirin as an antiplatelet dose. So it goes from 80 to 100 milligrams per kilogram per day down to 3 to 5 milligrams per kilogram per day. But of course, there could be some medical protocol. We continue with aspirin until platelet count returns to normal. If we still continue to have coronary abnormalities, the aspirin could be continued indefinitely. And then it's possible with children to use Coumadin if they have some kind of aneurysm involved with this as well. Okay, so on page 211 of ATI, it does talk about giving gamma globulin and also the aspirin that would be involved, and then some patient teaching. So we are going to talk about some more about that treatment. So what we're going to talk about in class on Monday would be, what is the nursing care of a child with infectious cardiac disease? What are some of the prior diagnoses? And also, what would be some priority interventions? Another area of concern that we're going to talk about is hypertension. And so children do get hypertension. Systemic hypertension can be primary, where there's no known cause, or secondary, there's identifiable causes. And some children have, with cardiac issues or kidney issues, they do have secondary causes. Usually in pediatrics, hypertension is secondary, and it lists renal disease or cardiovascular disease, or maybe some endocrine or neurological disorders that can cause hypertension. So how should we take care of it? Well, children need blood pressure screenings. So annually, children over 2 years old, some people wait till 3, but they should have at least an annual blood pressure check. And there are some charts out there that show normal blood pressure screenings. If you look in the back of your WONG, there's an appendix that has normal vital signs. With any illness, diagnosis or suspicion of, you might see, increased blood pressure with cardiovascular disease or seizures, neuro diseases. If a child has an abdominal mass that might be affecting the kidneys, that could cause blood pressure issues. Edema or ascites, maybe failure to thrive, or even unexplained headaches can all cause increased blood pressure. I also want to do a good medication history with kids as well. Another issue is hyperlipidemia, and kids are now we're seeing more and more kids at risk for high levels of lipids, and part of it is because of our rate of obesity. So we need to identify kids that are at risk and treat them early. Sometimes what they'll do, first of all, is look at cholesterol and fats. If that's not a response, some children are actually put on some hyperlipidemics, anti-hyperlipidemics, as a possibility. So this is kind of an overview of your cardiac chapters, and I want you to be ready to answer some of those questions and do some of that planning that we talked about. I also want you to be ready to look at these particular drugs and be able to discuss. We talked about the immunoglobulins. We are going to talk about digoxin, which is also known as lanoxin, and ACE inhibitors in the use with congestive heart. How does aspirin and NSAIDs play into it? What's the role of Lasix? What's the role also of aldactone as a possible drug that we use? All of these are used for different things on the heart. And then what are the implications for teaching if you're going to use them? So I look forward to having some more discussion with you in class and doing some care planning and some case studies. I also want you to be prepared for a cardiac quiz and know the terminology and some of the things that we've discussed here, maybe some assessments and other things to be ready for this, for our class time together. And I'll look forward to seeing you. Thank you so much.